Good morning. I'm Brenda Hughes, and I'm going to talk to you all about storytelling in public health. So when I was a kid, I always loved stories. I did, and I still get lost in books. I loved hanging out with my grandparents. We would read, we would cook, we'd garden, and they'd tell me stories. I wasn't going to mention this, but my granddad was really special to me. He was the one that always entertained why. I could ask him why until heaven and back. He never lost his patience. He would always try to answer me. Why is going to come up a lot in this presentation. Real quick about stories. I think that stories can show us the common threads that link us together as human beings, and I think that is why they have been so important to me. As much as I like stories, I have received stories that I didn't like as much. So I grew up on an Army base. I lived on an Army base till I was about 11 or 12. On an Army base, or I think any military base, race is not the thing, it's rank. And even with rank, because, well, back then it was our fathers going off to war or preparing to go off to war, there was still a real sense of community cohesiveness. Okay, so when I was in the 4th grade, I went to church with my best friends next door, Christine and Michelle. They happened to be white. They were having an old-fashioned day at their church, and I used to go to church with them. My parents weren't big churchgoers, but on this particular day, my mom decided to come with us to church. They were having an old-fashioned day at the church, and I was dressed up like a slave. My parents were not happy. That's when I got the first story I didn't like. The black story. They explained racism to me. They explained how that was going to play out in my life. So that was story number 1 I didn't like. The next story I got is when I experienced sexism. Then I got the woman story and how that was going to impact my life. Then I got the black woman story. That's when I experienced intersectionality. And I don't think my folks used that term, but that's what it meant. I know that now. Those stories made me feel powerless. The injustice of it, the unreasonableness of it, really just made me angry. And I realize now that was probably the start of my public health career journey, because I was going to fight injustice one way or the other. So when I finally got to practice public health, I made some really big mistakes. As an intern on my first year of grad school, I worked at a HIV/AIDS clinic that served African American people that, of course, they were infected with the virus. I worked with men who had just gotten out of prison, and we wanted to keep them from going back to jail, and it was a job training program, life skills program that I was running. One of the participants' name was Rodney, and he had missed several sessions. Rodney was a black guy, because again, we're serving this population. And in my over-eagerness to form a connection with Rodney, I told Rodney that I knew what Rodney was going through. And Rodney told me that I had no way of knowing what he was going through because I wasn't a black man, I'd been to prison, I didn't have HIV/AIDS, and I wasn't poor. And I'm not sure what happened to Rodney, but I still wonder if I said something to him that day that may have impacted his progress. I feel like I turned him off. I'm going to move up a few more years when I started working after I graduated. So I moved to the low country of South Carolina, that's where I live now, and I started working with different coalitions. I cover 6 counties. So I come to the low country from Philadelphia, and I know everything about public health now. I came and I'm armed with all the data, the facts and figures, the evidence-based interventions. I had read this series in the local paper called The Corridor of Shame, which is what they call I-95. I'm looking at Paige because she knows. The corridor of shame is what they call it. So, I'm coming to these meetings and I'm armed with all this data, and Ethel, who's one of my community partners, told me that I knew too damn much for her. That was not a compliment. That was a dig. She told me I was basically being very arrogant, I wasn't listening, and I did not understand the community. Both times, I really thought I was meeting people where they are. Community-based participatory research is part of my practice. I knew it on an academic level, but I did not know it on a practical level. I realized that context is important. Data exists to tell a story. It is not just to write research papers. Sorry for all the academics out here. That's not what it's not where it should exist. If you want to meet people where they are, you have to find out where they are. And you do that by talking to people. I finally realized I was being shunned. It didn't take long. So I regrouped and I did some good old-fashioned community organizing. I went to every church fundraiser. I went to every community event I heard of. I did community cleanup efforts. We did walking tours. I took copious observational field notes, hoping I could try to understand what was happening. I think one of the most important things I did was when I would go to meetings, I stopped talking. I started listening, and I'm the note taker. I'm a horrible note taker, by the way, but I'm the note taker. Because I realized I had made a huge mistake, and I just needed to dial it all the way back. So that's what I did. Luckily, things started to slowly turn around. The community slowly began to let me in, and we were able to work on capacity building efforts. And I want to say something really quick about trust. I will not violate the trust I have in my communities now. It's not an option. I won't do it for my agency. I won't disrespect the community members like that, and I will not jeopardize the reciprocal trust that we have in each other. So one of the first things we did in the coalitions was to start looking at the social determinants of health and trying to determine what were the root causes of those. Again, why? Why are these things happening? And what the main question we focused on back then was access. Access to food, access to health care, access to transportation. A lot of it is structural as far as access in our communities. For example, rural hospitals are closing. Providers don't want to move to a rural area. That's not the dream they had when they went to medical school. We don't have a lot of healthy food outlets. I go to some communities where there are no grocery stores, but they managed to put a liquor store there. I still don't understand that. So we worked on what we could because it was a grassroots effort. So we did a lot of community gardens. We did some community-supported agriculture projects. We worked on some infrastructure changes to improve physical activity opportunities in our communities. So one of the things I thought was we thought was important, because I'm taking myself out of it. See, I still have to catch myself doing that. There was a lot of parks there, but they were not safe for kids. That was one of the first things we worked on. And then improving the sidewalks. And we did that through a penny tax that the counties had implemented. And we asked for money for that penny tax to pay for these changes. And we also got some grant funding. But we want to include it in the county's plans. And so that's what we did. And we did all of that so we could build capacity to scale up at some point. And that was the long-term goal. Then something strange started to happen, and it was right around the time when the administration changed. I started really experiencing a lot of macroaggressions. Some of you might understand, I think probably microaggressions, that's just part of what I have to deal with every single day. So I'm used to that. Okay. Macroaggressions started happening all the time. I'm frustrated. Can I do this work? Why do I even want to do this work? Nothing seems to change. I found the fellowship. And the fellowship has given me, first of all, it reminded me why I'm doing the work. It's also given me some new tools to do the work. I'm thinking specifically about the distributive leadership model. We changed that so that it would be more a sustainable model. So now we are creating new leaders. We are able to more quickly come to consensus. It allows for a shared commitment. And we now view the community holistically. Another thing the fellowship has, the gift of a fellowship has been the reflection part, which is also the most challenging part for me anyway, because that's not my jam. I don't really reflect, but I think I'm being intentional. I think I'm being intentional, but then I realized if I'm not reflecting, I'm not being intentional. When I started doing that, the conversation in our coalition started to shift, and I think I started feeling safe, and I think the coalition started feeling safe, and we started having some really rich discussions. So the last round of focus groups we did was last week, and I went through the data, and I was going through it, and I was like, wow, my project didn't go the way I wanted to. I thought we could do the focus groups, write some policy briefs, advocate for policy change at the state level. The focus group said something different. Respect was the top priority. Then there's the school lunch programs. There's problems with that. Gentrification is happening. I live on the coast. That land is now valued, and they want it for what they want it for. We want to create a sustainable food system. One of my partners works at the local food bank, and she said the local food banks are not a way to create a sustainable food system. That is a safety net program. Zoning. My girl Ethel, who told me I knew too damn much, told me, don't come back here, Brenda, and talk to me about food access if you're not going to talk to me about a grocery store being in our community. Now, Ethel is my good friend. I call her my girl Ethel. Some people think her first name is my girl. It's not, it's Ethel. So then that made us say, well, how does that even happen? It's a zoning issue. LGBTQ issues came up for the first time ever. I was so surprised. So we're going to start collecting data to understand what that looks like in our communities. Mental health came up. I was surprised. What I realized is that there was a common thread through all of those, and that was respect. And I'm thinking about how that respect relates to equity. This also gave us a new set of whys. So we have some more stuff to explore. But the list that we had, it was just so much different from what we had been working on. So I consider this project a win because it has created a richer set of data. Our coalitions work so much more effectively. We have hard conversations. We have argued over the last year, but it doesn't break the coalition. So, in closing, not quite, because I want to just say to Seble, when you were getting all those readings and it was like about disability, about mental health, and I always thought about equity. I hate to say this, it's gender or race, and it's not. It's so much more than that. So the way I approach the work has changed completely. And I think about how we can incorporate the things that came through in the focus groups as one holistic equity issue. I hope that we can accomplish that. So even though our policy work is still in progress, I'm hopeful that it will continue. I want to thank all of y'all for your comradeship, for the humor, for the challenges. I hope that we continue to work together. Thank you, faculty and staff, for your guidance and support. Thank you.